Welcome to the Deep Dive, the show where we really get into the weeds on complex subjects, making dense information clear, understandable, and, well, useful.
That's the goal.
Our mission, as always, is to give you a genuine shortcut to being truly well-informed. Today, we're taking on something huge: cardiac surgery and the incredibly precise world of anesthetic management.
It's a fascinating field, absolutely critical.
Yeah, this isn't just scratching the surface. We're aiming for a deep immersion, exploring a field that saves and fundamentally changes lives across the globe.
It really does. The impact is enormous.
And the numbers, they just tell the story, don't they? Cardiovascular disease, it's still the #1 killer worldwide. A massive 31% of all deaths.
Staggering, really.
And the WHO, they're projecting, 23.6 million deaths from cardiovascular disease by 2030, mostly coronary artery disease, CAD.
CAD is definitely the big driver, yeah.
And here in the U.S., it's 1 in every 3 deaths, the economic cost, around $351 billion a year. That's like $1 out of every 7 spent on healthcare. Just think about that.
It's a huge burden on the system financially and in terms of human life.
And it's not just CAD, right? With populations getting older, we're seeing this rise in degenerative valvular heart disease, VHD.
That's right. Valve problems are becoming much more common.
Yeah, currently over 290,000 heart valve operations globally each year, and they expect that to triple by 2050 to 850,000 a year.
The projections are really quite startling. It reflects that aging demographic shift.
And both CAD and VHD, often they lead down the path to heart failure. That affects over 6.5 million Americans, 64 million worldwide.
And outcomes can be pretty grim.
Yeah, a 45% mortality rate for symptomatic patients, that's worse than most cancers.
It puts the seriousness into perspective.
So that brings us right to the core challenge we're tackling today. How do clinicians care for these incredibly high-risk patients? They're undergoing these super complex surgeries using technology that's just mind-blowing.
It requires immense level of skill, coordination, and understanding.
I remember reading about Richard Morris, a pioneer in cardiothoracic nurse anesthesia. He had this saying, something like, "It's simple, really. Just take care of the pump, pipes, and volume."
Ah, yes. Deceptively simple.
Right. Sounds easy, but what does it really mean? That's what we're unpacking today. We're going deep into cardiac anesthesia and surgery, the physiology, the advanced procedures, the cutting-edge devices.
We'll break down that pump, pipes, and volume concept piece by piece.
Exactly. And by the end of this deep dive, our goal is for you, the listener, not just to know about this field, but to start to master the information, to really grasp the why behind every critical decision, just like the elite professionals do.
Understanding the fundamentals is key to that mastery.
Okay, let's get started on that journey. Let's unpack this. Where do we begin?
Well, the absolute bedrock is understanding normal cardiac function, the pharmacology involved, and how the body responds to disease. And central to all of that is the concept of myocardial oxygen supply and demand.
The balancing act.
Exactly. It's this constant, very delicate balancing act. And getting it wrong, well, myocardial injury, like a heart attack during or after surgery, it's the most frequent, most serious complication we face.
The #1 cause of morbidity and mortality post-op?
Pretty much, yeah, for cardiac and major vascular surgery. So optimizing that oxygen balance, that supply versus demand, it's priority #1.
Okay, so break down the mechanics for us. How does that supply actually work?
Right. So think of your heart muscle, the myocardium. It needs a constant flow of oxygenated blood delivered by the coronary arteries. The pressure driving that flow, especially during the heart's relaxation phase, is the coronary perfusion pressure, or CPP.
And how do we figure that out?
We calculate it. You take the aortic diastolic blood pressure, that's the bottom number on your BP reading when the heart's filling, and you subtract the left ventricular end diastolic pressure, the LVEDP.
Which is the pressure inside the main pumping chamber just before it squeezes.
Precisely. That difference, DVP minus LVEDP, gives you the CPP. The actual amount of blood flow then depends on that pressure divided by the resistance in those coronary vessels.
Makes sense, like Ohm's law, kind of.
Very similar concept, yes. Now, in a healthy heart, there's this amazing thing called autoregulation.
Right, where the heart adjusts its own blood flow.
Exactly. It keeps the coronary blood flow pretty constant, even if your overall mean arterial pressure, your MAP, swings between, say, 60 and 140 millimeter Hg. The vessels just constrict or dilate as needed.
Smart system.
Very. But that system breaks down in patients with significant coronary artery disease. Those calcified blockages, they prevent the vessels from adjusting properly.
So the flow just follows the pressure.
It becomes completely pressure dependent, especially once the MBP drops below about 70 millimeter Hg. Below that, the heart's ability to protect its own blood supply is severely compromised. That's a danger zone.
And you mentioned diastole being key for perfusion.
Hugely important.
Mhm.
About 80% of the blood flow to the left ventricle, the main workhorse, happens during diastole when it's relaxed and filling,
Okay.
which is why heart rate is so critical. If the heart rate goes up, diastole gets shorter. Less diastolic time means less time for coronary perfusion. It directly cuts into the oxygen supply.
So faster heart rate equals less oxygen supply. That's counterintuitive almost.
It is, but it's fundamental. And there's another layer, the subendocardium.
The inner layer of the muscle.
Exactly, the innermost third. Think of it like the core. It's the most vulnerable part, facing the highest pressure inside the ventricle, especially during systole.
So it gets squeezed the hardest.
Right. And that makes it the most susceptible to a supply-demand mismatch. Now, imagine a scenario where heart rate goes up and the pressure inside the ventricle, LVEDP, goes up simultaneously.
Which probably happens when a patient is stressed or sick.
Very common. This creates a really dangerous situation. You decrease oxygen supply because of the fast rate shortening diastole, and you increase oxygen demand because the heart is working harder against higher pressure.
A double hit.
Precisely. And we know from large studies that high heart rates are linked to worse outcomes, more cardiac problems. So maintaining adequate MAP for perfusion and a low heart rate for diastolic filling time, that's absolutely critical, especially with CAD or high LVEDP. Intraoperative hypotension, strongly linked to myocardial injury later. These are non-negotiable targets.
Okay, so if we zoom out and look at the whole supply and demand picture.
It's a whole system, supply side.
Yeah.
You've got the coronary anatomy itself, any blockages. Then the coronary perfusion pressure we just discussed, AODP, LVEDP. Coronary resistance matters. Diastolic time, which is all about heart rate.
Yeah.
And then the blood itself, the oxygen content, hemoglobin level, saturation, how easily oxygen comes off hemoglobin.
Got it. Supply factors.
Demand side. Heart rate, again, faster rate means more work. Contractility, how hard the heart squeezes. And left ventricular wall stress.
Which depends on pressure, the size of the ventricle, and wall thickness.
Well, exactly. And wall stress is heavily influenced by preload the filling volume and afterload the resistance it pumps against.
So what really jumps out is that heart rate and the pressure inside the ventricle affect both sides of the equation.
You nailed it. They uniquely hit both supply and demand. That's why they are such crucial targets for us to manage constantly in the OR. It's all about balancing those two.
And when that balance tips the wrong way, that's ischemia.
That's the start of the ischemia cascade. Think of it as a domino effect. First, the supply-demand imbalance, then biochemical changes inside the cells, then often the earliest sign we can detect, ECG changes, ST depression, maybe elevation, T wave changes.
The electrical signals go first.
Often, yes. If it progresses, then you get clinical symptoms. Angina, sweating, shortness of breath. And if it continues unchecked, myocardial infarction heart attack, congestive heart failure, even cardiogenic shock.
Understanding that whole sequence lets clinicians jump in early.
That's the whole point. Detect the subtle warnings, intervene before irreversible damage occurs. Read the heart's signals.
It's amazing how the body signals distress. But you mentioned earlier, the heart isn't just passive. It has its own ways of coping, right? These self-preservation things.
Absolutely. It's remarkably adaptive. We see these phenomena, stunning, preconditioning, and hibernation. Understanding these gives you a real appreciation for the heart's resilience.
Okay, let's start with stunning. What's that?
Imagine the heart muscle gets briefly starved of oxygen, maybe less than 20 minutes. Not long enough to cause cell death or necrosis,
Okay.
but the muscle is stunned. It temporarily loses its ability to contract properly. It's like a muscle cramp almost. It recovers, but it can take hours, maybe even a full day.
And that's why some patients need heart-strengthening drugs after bypass.
Exactly. Very common reason for needing inotropic support for 12, maybe 24 hours post-CPB. The heart just needs a bit of help getting back up to speed after being stunned.
Makes sense. What about preconditioning? That sounds intriguing.
It's fascinating. Short, non-damaging episodes of ischemia, just a few minutes, actually make the heart more tolerant to a longer, potentially damaging ischemic event later on.
So a little stress prepares it for a bigger stress, like training.
Kind of like that, yeah. It primes itself, builds resilience. And what's really clinically relevant is that almost all the inhaled anesthetic gases we use, except nitrous oxide, actually produce this preconditioning effect.
The anesthetic itself protects the heart.
Yes. It protects the myocardium, reduces potential infarct size if ischemia does happen. This protective effect is a major reason why inhalation anesthesia has seen a resurgence in cardiac surgery, especially for stable patients. Research is still ongoing for unstable patients, but it's a powerful effect.
Wow. Okay, and the third one was hibernation, like a bear.
Exactly like that.
Yeah.
This happens with chronic, long-term blockages causing a steady state of reduced blood flow. The heart muscle adapts by reducing its contractile function to match the limited oxygen supply available.
It powers down to survive.
Precisely. It's a self-preservation mechanism. Hibernation can also develop after multiple episodes of stunning. The critical thing clinically is telling the difference between hibernating tissue, which is still alive, and necrosed tissue, which is dead scar.
Why is that difference so important?
Because if the tissue is just hibernating, restoring blood flow through stenting or bypass surgery can lead to significant improvement in heart function. Somewhere between 20% and 40% of patients with chronic ischemic LV dysfunction see major gains if the tissue is viable.
So identifying viable tissue is key to treatment decisions. How do you do that?
We use advanced imaging. SPECT scans look at blood flow at stress and rest to see if defects fill in, indicating viability. PET scans use glucose uptake as ischemic tissue switches metabolism. Dobutamine stress echo uses medication to stress the heart and see if wall motion improves or worsens, indicating viability. And cardiac MRI gives amazing detail on function and wall thickness, also used with dobutamine.
A whole toolkit to assess viability.
Yeah, these tests, along with others like CT angiograms and cardiac cath, give us that comprehensive picture, the anatomy, the function, and crucially, the viability guiding whether revascularization will actually help the patient.
Incredible. Okay, so that's the heart's own survival kit. But bringing it back to the patient in front of us, managing them. It sounds like heart failure itself isn't just one thing. There are different types, different classifications.
Oh, definitely. Not all heart failure is the same, and understanding the specifics is crucial for tailoring management. We use two main systems. First, the ACC-HA stages, stages A through D. State A is just high risk, no symptoms or structural changes yet. Stage D is end stage, refractory failure needing advanced therapies.
So that tracks the progression.
Right. Then we have the NYHA functional classes, I through IV. These focus on symptoms and limitations. Class I, no symptoms with ordinary activity. Class 4, symptoms even at rest.
And you use both together?
Usually, yes. They give a really comprehensive picture of risk and severity, which directly informs how we approach treatment for that individual patient.
And you mentioned systolic versus diastolic failure earlier.
In critical distinction, systolic failure, often younger males, maybe post-MI. The key is a depressed ejection fraction, usually under 40%. The LV chamber is often dilated, bigger than normal. The pump is weak.
Okay.
Diastolic failure. Often elderly females, maybe with hypertension or diabetes, here the ejection fraction is preserved, often over 40%. The LV cavity size is normal, but the muscle wall is thick and stiff concentric hypertrophy. The pump squeeze is okay, but it can't relax and fill properly.
So completely different problems driving the failure, which means different anesthetic approaches.
Absolutely. For systolic dysfunction, the weak pump, you have to rigorously avoid anything that depresses contractility further.
Yeah.
You need to be ready with inotropes, especially coming off bypass. Preload looks low, but you have to avoid overload because the dilated ventricle is already stretched.
Right.
For diastolic dysfunction, the stiff pump, volume is critical to stretch that non-compliant ventricle and allow filling. But too much volume is disastrous, causing pulmonary congestion quickly. T becomes invaluable here for guiding fluid titration in real time. Contractility is usually okay, but you still avoid depressants.
Fascinating. What about the right side of the heart? Right heart failure.
That's another specific challenge, especially when combined with pulmonary hypertension, PHTN. The main goal there is reducing the afterload on the right ventricle, making it easier for the RV to pump blood into the lungs.
So avoiding things that squeeze the pulmonary arteries.
Exactly. Avoid hypercarbia, high CO2,
Yeah.
hypoxemia, low O2, acidosis. Avoid certain anesthetics like nitrous and desflurane. Even avoid Trendelenburg position. All those things increase pulmonary vascular resistance, PVR, making the RV work harder.
So management involves careful fluids, maybe diuretics.
Yes, and sometimes venodilators like nitroglycerin. And critically, remember the RV usually gets blood flow throughout the cycle, but when it's really distended and failing, its perfusion becomes diastole dependent, just like the LV. So maintaining mean and diastolic pressures is key.
And drugs for low pressure in RHF.
We often prefer agents with combined inotropic and vasopressor effects, ephedrine, epinephrine. Vasopressin is also great because it constricts peripheral vessels but has minimal or even beneficial effects on PVR. Milrinone is useful too. Improves contractility and vasodilates, good for both RHF and PHTN. And for severe cases, inhaled pulmonary vasodilators like epoprostenol can be life-saving.
Okay, that's a really detailed look at the pump side of things. Now let's switch gears to the pipes, the coronary arteries themselves, and restoring flow when they get blocked. This is CABG territory, right?
Exactly. Coronary artery disease, CAD, and myocardial revascularization. And yes, on-pump coronary artery bypass grafting, CABG, is still the most common cardiac surgery performed worldwide.
What makes someone a candidate for CABG instead of, say, stents?
The indications are pretty specific. Generally, it's recommended for patients with 3-vessel disease, significant disease in 2 vessels, including the proximal LAD, the main artery down the front, or even just proximal LAD disease if a lead graft will be used. Also, patients who failed stenting or have blockages that just aren't suitable for stents.
And it offers better outcomes than just medication in those cases.
Yes, for these specific groups, studies show CABG leads to lower mortality and fewer major cardiovascular events compared to medical management alone.
So before surgery, you're reviewing all the tests.
Meticulously. Angiograms to see the blockages, echo to assess ventricular function, which directly relates to post-op risk, and checking for other issues like valve disease.
What about patients who already have stents? That must complicate things.
It does, especially regarding antiplatelet drugs like Plavix or Brilinta. If a bare metal stent went in within the last month or a drug-eluting stent within 6 months, stopping those drugs carries a high risk of the stent clotting off. It requires careful discussion with the whole heart team, cardiology, surgery, anesthesia, to balance that risk against surgical bleeding risk. In emergencies, though, we might continue aspirin or even GPI-IVI inhibitors despite the bleeding risk.
And the anesthetic strategy during CABG? Back to supply and demand?
Always. Optimize supply, minimize demand, constant ECG and T monitoring for ischemia.
Yep.
Key goals. Keep the MAP at or above preoperative levels for coronary perfusion, but keep heart rate and LVEDP low.
Beta blockers help with rate.
Yes, and continuing them is a quality measure. For high blood pressure, nitroglycerin is often preferred, lowers BP, reduces preload, and actually dilates coronary arteries. For low pressure, phenylephrine gives a quick boost.
Okay, let's talk about the grafts themselves. What are the new pipes made of?
The most common conduits are the internal thoracic arteries, especially the LIDA left internal thoracic artery for the LAD. That's the gold standard arterial graft. Saphenous veins from the leg are very common too. And the radial artery from the arm is another arterial option.
Arterial grafts last longer.
Generally, yes, they have better long-term patency, especially for really tight blockages.
Yeah.
But arteries like the radial can sometimes spasm, competing with native slow. We treat that with topical papaverine or IV calcium channel blockers or nitro.
And harvesting these takes special care.
Absolutely. Getting the LIDA requires specific table positioning, lung deflation, careful arm padding to avoid nerve injury. Veins are often harvested endoscopically now, which is less invasive, and vein grafts have to be reversed so their valves don't block flow.
Any specific complications during grafting?
Reoperations are tricky because old grafts might be stuck right under the sternum. Getting the graft length just right is crucial. Too short or too long causes kinks. And there's always a risk of tiny clots or debris getting into the coronaries or spasm during the connection.
Beyond the traditional on-pump CABG, you mentioned off-pump surgery, OPCB, where the heart keeps beating. That sounds technically demanding.
It is. OPCIB is performed on a beating heart, usually in patients with reasonably good LV function who can tolerate the hemodynamic swings.
What are the benefits of doing it that way?
Often less bleeding, fewer transfusions, patients get off the ventilator sooner, mobilize faster, go home earlier, lower wound infection rates too, and better cosmetic results. It can be a great option for the right patient.
But the anesthesia must be different.
Very different. No pump prime means we have to manage fluids carefully with crystalloid or colloid ourselves. We have to actively keep the patient warm since there's no bypass machine heat exchanger. Anticoagulation might be partial or full heparinization, depending on the surgeon, and we don't routinely use antifibrinolytics. And we monitor labs like ABGs and electrolytes frequently.
And the surgery itself, lifting the beating heart, that must affect things dramatically.
Dramatically. Surgeons use stabilizers and retractors to lift and position the heart, sometimes almost vertically to reach posterior vessels. This compresses chambers, distorts valves, it causes significant hemodynamic compromise, and can induce acute ischemia.
So you have to be ready to switch to bypass.
Absolutely. Constant readiness for conversion to on-pump is essential if the patient destabilizes. Reaching posterior arteries like the PDA or circumflex requires the most manipulation and carries the highest risk.
How do you manage the anesthesia during those maneuvers?
Intense communication is key. During the distal connections, we aim for a high MAP, maybe 90, 100 millimillimil Hg, to maintain coronary perfusion pressure. We treat hypotension aggressively with volume, pressors, bolus, or infusion. Steep Trendelenburg position helps. Sometimes inotropes are needed. Then, when the heart goes back to its normal spot, you have to anticipate pulling back on support quickly. Later, for the proximal graft connections on the aorta, we lower the MAP target to maybe 60, 70 millimil Hg while the side clamp is on. It's a constant dynamic adjustment.
Wow, so we've covered the pump and the pipes. Now let's get into the heart's valves. These intricate gates, when they fail, create entirely different problems needing totally specific anesthetic plans.
You're spot on. Valvular heart disease, VHD, forces abnormal pressure and volume loads onto the heart chambers, leading to significant structural and functional remodeling over time. Managing it effectively demands a really deep understanding of the specific valve's anatomy, its pathophysiology, and how the disease naturally progresses.
And echo is key here.
Echocardiography is indispensable. It gives us that real-time view of the valve's structure and function. Fundamentally, flow across any valve depends on three things: the valve area, the pressure gradient across it, and the time available for flow, systole or diastole.
So you manipulate hemodynamics to optimize that flow.
Precisely. We manipulate four main parameters: heart rate and rhythm, preload, afterload, and contractility. The goal is always to maximize forward flow through stenotic narrowed valves and minimize backward flow through regurgitant leaky valves. It's also worth noting that HOCM, hypertrophic obstructive cardiomyopathy, while not strictly a valve issue, often requires similar hemodynamic management to aortic stenosis because the outflow obstruction it causes.
Okay, let's start with aortic stenosis AS, the pressure problem. When is surgery indicated?
Valve replacement is strongly recommended, class 1, for anyone with severe AS who has symptoms. Also for asymptomatic patients if their LV ejection fraction drops below 50% or if they're having other cardiac surgery anyway. Surgical aortic valve replacement, SAVR, is class I for all risk levels. But now, transcatheter aortic valve replacement, TADR, is class I for prohibitive or high-risk patients and class TI for intermediate risk.
And the anesthetic management is tricky.
Very. Preload needs to be high normal. That stiff LV needs volume to fill. Heart rate needs to be slow normal. Tachycardia is terrible. It cuts diastolic filling time for both the ventricle and the coronaries, causing ischemia. Bradycardia kills cardiac output. Sinus rhythm is vital for that atrial kick.
And blood pressure.
Hypertension is better tolerated than hypotension, but you don't want it excessive. Hypotension, however, must be treated immediately and aggressively with vasoconstrictors like phenylephrine. If they arrest, chest compressions are often ineffective because of that stiff, thick ventricle. Remember, the pressure gradient, an aortic SPP of 180 might mean an LV pressure of 260. Any drop in pressure or spike in heart rate massively increases oxygen demand and risks severe ischemia.
Got it. Now, hypertrophic cardiomyopathy, HCM or HOCM, that's genetic.
Yes, inherited, affecting about 1 in 500 people. It's a major cause of complications. Think of ventricular arrhythmias leading to sudden death, especially in young athletes. Progressive diastolic heart failure, even with good squeezing function, and atrial fibrillation with stroke risk. Before opioids, it was the leading cause of sudden death in young people.
How is it managed?
Medically, beta blockers, calcium channel blockers, disopyramide. Maintaining sinus rhythm is key. High-risk patients get ICDs, implantable defibrillators, but we have to suspend their anti-shock function during surgery with cautery use. Surgically, septal myectomy is preferred over alcohol ablation for significant obstruction. Often, mitral valve issues need fixing at the same time.
Anesthetic goals for HCM.
High normal preload volume is crucial. Strictly avoid increases in heart rate or contractility, as that worsens the outflow obstruction by pulling the mitral valve leaflet toward the septum. Avoid sudden drops in afterload too. And be aware, myectomy can disrupt the conduction system, causing heart block needing pacing.
And you test the repair afterwards.
Rigorously. After bypass, we use PE and deliberately stress the heart increase rate and contractility with drugs like isoproterenol, decrease BP to mimic exertion. This reveals any leftover obstruction or mitral valve issues that need further fixing.
Okay, switching gears to leaky valves. Aortic insufficiency, AI or AR. Volume overload.
Exactly. Blood leaks back from the aorta into the LV during diastole. Causes volume and pressure overload. Can be acute trauma, infection, dissection, which causes rapid deterioration because the LV can't cope suddenly, or chronic, like valve degeneration.
Acute AI sounds really dangerous.
It is. Rapid LV dilation, high filling pressures, poor coronary perfusion, ischemia, pulmonary congestion, maybe even secondary mitral regurgitation. CE is vital for urgent diagnosis and surgical decisions.
Anesthetic plan. I remember fast, full, and forward.
That's the mnemonic. High normal heart rate to minimize diastolic time for regurgitation. Avoid bradycardia. Keep volume high normal for forward flow, but be careful not to overload post-bypass. Reduce afterload with vasodilators to encourage forward flow out to the body. And watch for LV distension on bypass if the heart rate is slow or arrested may need an LV vent.
Now, mitral stenosis, MS, obstructed flow from LA to LV.
Right, mechanical blockage. Repair or valvotomy is preferred over replacement if possible. Often done with AF ablation procedures like MAZE or PVI if needed.
Anesthetic goals here, opposite of AI almost.
In some ways, low normal heart rate is priority 1 to maximize diastolic filling time across the narrowed valve. Rapid rates are disastrous. Control the rate if in AF. Avoid anything that increases pulmonary hypertension, which is common, high CO2, low O2, certain gases, Trendelenburg. Volume is tricky. LV is chronically underfilled, needs preload, but too much causes pulmonary edema. RV failure can be a big issue post-op.
And the most common valve problem, mitral regurgitation, visitor leaky mitral valve.
Yes, most common VHD. Blood goes backward from LV to LA during systole, can be primary, valve problem, or secondary. LV dilation stretches a normal valve. Acute MR, like from a ruptured papillary muscle, is an emergency LA candex. LA can't compensate, leads to rapid pulmonary edema, RHF.
Anesthetic plan for Mr. Allechnad, similar to AI again?
Similar principles. Fast, full, and forward. High normal heart rate minimizes regurgitant time. Avoid bradycardia. Judicious preload. Reduce afterload with vasodilators to promote forward flow. Be aware that fixing the leak increases afterload, potentially unmasking LV dysfunction post-bypass, so inotropes might be needed. And watch for SAM systolic anterior motion post-repair with TE.
And repair is better than replacement.
Definitely recommended if feasible. Better LV function, survival, fewer complications, less anticoagulation. Techniques range from open to robotic, involving resections, annuloplasty rings. For high-risk patients, the MitraClip offers a percutaneous option.
Okay, we've thoroughly covered the heart's structure, pump, pipes, and valves. Now let's shift to that third element from Richard Morris, the pump, but this time the artificial one, cardiopulmonary bypass, the heart-lung machine.
Right, cardiopulmonary bypass, CPB. It's the technology that makes most modern cardiac surgery possible by providing that still, bloodless field surgeons need.
How does it actually work, in simple terms?
Essentially, we divert all the venous blood coming back to the heart away from the heart and lungs into this external extracorporeal circuit. That circuit oxygenates the blood, removes CO2, filters it, controls temperature, and pumps it back into the patient's arterial system.
So it completely takes over for the heart and lungs temporarily.
Exactly. Artificial ventilation, perfusion, temperature regulation. And while the heart is stopped, we protect it with cardioplegia, that cold, high-potassium solution that stops electrical activity and cools the muscle.
What are the main parts of this circuit?
There are 5 basic components. First, the venous reservoir collects the drained blood. It often has a separate section, the cardiotomy, for blood suction from the field. Drainage can be gravity-fed or vacuum-assisted, VAVD, especially with smaller cannulas, though VAVD has risks like hemolysis or air embolism.
Okay, reservoir, then.
The main pump, usually electric. Older roller pumps give constant flow but can damage blood cells more. Newer centrifugal pumps use an impeller, cause less damage, but flow depends on preload afterload, so need a flow meter. And crucially, there's always a hand crank for emergencies.
Got it. Pump, next.
The oxygenator. Modern ones are membranes, hollow fibers, where gas diffuses across to oxygenate blood and remove CO2, mimicking the lungs.
Lungs replaced, what else?
A heat exchanger, usually built into the oxygenator, lets the perfusionist precisely cool and rewarm the blood, controlling the patient's body temperature.
Temperature control, and finally.
The arterial filter. Last stop before blood returns to the patient. Catches air bubbles, tiny clots, debris, often integrated with the oxygenator now too.
Are there other gadgets involved?
Yes, several key accessories. Cardiotomy and basket suction lets the surgeon suck blood from the field. That blood can go back to the reservoir, filtered but might have debris, or to a cell saver, which washes and concentrates the red cells less inflammatory, usable even before full heparinization, but removes plasmaplatelets. Then there's the left ventricular, LV vent. A catheter, usually in the LV via pulmonary vein, drains blood that still sneaks into the LV from bronchial diffusion arteries or a leaky aortic valve. Prevents the LV from distending, which protects the muscle and ensures good cardioplegia delivery. And finally, a dedicated cardioplegia pump system controlled by the perfusionist with its own heat exchanger to deliver that protective solution at the right temperature, rate, and pressure.
An incredible system, but running the blood outside the body, anticoagulation must be absolutely essential, and protecting the blood itself seems critical.
Paramount on both counts. Anticoagulation is mandatory before any cannulas go in. Heparin is the standard, usually 400 units per kilogram mortar. It works by binding to antithrombin III, inhibiting thrombin, and factor Xan.
How do you know you have enough?
We monitor it constantly using point-of-care tests. Most commonly, the activated clotting time, or ACT. Baseline is maybe 80-120 seconds. The goal before starting CPB is usually over 480 seconds. Some centers use heparin concentration assays for more precise dosing and reversal. We check it every 20-30 minutes on bypass.
What if the ACT doesn't go up enough? Heparin resistance.
Yes, defined as an ACT under 480 despite 600 units of heparin. Usually suspect antithrombin III deficiency. Treat with fresh frozen plasma, FFP, ATI3 concentrate, or recombinant AT3.
And what about HIT heparin-induced thrombocytopenia?
That's a serious immune reaction. If a patient has a history of HIT, we only use heparin during CPB if their antibody screen is negative. Avoid it in flushes. Avoid heparin-bonded catheters. If they have acute HIT or positive antibodies, surgery is postponed if possible. If urgent, bivalirudin, a direct thrombin inhibitor, might be used instead.
Okay, anticoagulation covered. Now, myocardial preservation cardioplegia. Tell us more about that.
Cardioplegia solutions are designed to stop the heart quickly, keep it cool, and provides a metabolic support. Most common are hyperkalemic crystalloid solutions mixed with the patient's own blood, like Buckberg solution, often a 4.1 blood to crystalloid ratio. The first dose is usually very cold, 25 degrees C, with high potassium, 20 to 30 MQL. Maintenance doses are still cold, but with lower potassium, 12-16 MQL. The goal is to get the heart muscle temperature down to 8-10 degrees C.
Are there other types?
Yes, del nido cardioplegia is popular now, even in adults. It's a 1.4 blood to crystalloid mix, often given as a single dose that can last up to 180 minutes. Benefits include less need for insulin and time cost savings. Whole blood microplegia is another approach, concentrated additives mixed with blood, less hemodilution, maybe better caloric support, longer redosing interval.
How is it delivered?
Dosing depends on time, volume, and myocardial temperature. It's reduced roughly every 15-20 minutes for traditional solutions, or when ECG activity reappears or the heart temperature rises. Delivery can be antegrade forward flow through a catheter in the aortic root above the cross clamp, or directly into the coronary openings or bypass grafts. That usually achieves a rest in 1 to 2 minutes. Or it can be retrograde backward flow via a catheter placed in the coronary sinus, the main vein draining the heart.
Risks with retrograde.
Can cause dysrhythmias or hypotension during placement. And just before removing the cross clamp, a terminal hot shot is often given a single dose of warm 37 degrees C blood cardioplegia, containing metabolic substrates like glucose, glutamine, and aspartate to help kickstart myocardial recovery.
So even with all this tech, there are still risks. You mentioned blood conservation earlier. And the body's reaction to bypass?
Absolutely. Blood conservation remains a huge focus. Cardiac surgery uses 10-15% of the national blood supply, and transfusions carry risks worse survival, more infections. Yet blood is scarce and costly.
So how do you minimize transfusions?
Several key techniques. Antifibrinolytics like Amicar or tranexamic acid are standard. They inhibit clot breakdown. Blood salvage using cell savers recycles red cells from surgical suction or the CPB circuit. Limiting the pump prime volume with mini circuits or retrograde autologous priming, RAP, reduces initial hemodilution. And ultrafiltration on bypass removes excess water concentrated in the patient's own blood components.
And the body's reaction to CPB, you called it SIR.
Systemic inflammatory response syndrome. It's triggered by blood contacting the foreign surfaces of the bypass circuit. It can range from mild to severe. Multiple organ dysfunction syndrome, MODS.
What causes it?
It's complex. Ischemia-reperfusion injury, microemboly, endotoxin release from the gut, endothelial damage, activation of immune complement to coagulation cascades, plus a massive stress hormone release, cortisol, catecholamines, vasopressin. No single magic bullet stops it, though targeting multiple pathways is promising. Steroids haven't consistently shown benefit.
Does it affect the lungs specifically?
Yes, pulmonary complications are common. Atelectasis, collapse, and pleural effusions happen in about 60% of patients. Severe acute lung injury, ALI, or ARDS, can occur too, due to emboli, long bypass times, and leaky capillaries from SIRS. Using low tidal volume ventilation during CPB helps, as does careful lung re-expansion afterwards. Inhaled epoprostenol can also help reduce pulmonary pressure.
And bleeding issues, too. Coagulopathy.
Yes, CPD dilutes and damages platelets and clotting factors. This manifests as increased bleeding. Antifibrinolytics and techniques like hemodilution help mitigate this.
It truly sounds like a symphony, every instrument playing its part. Let's follow the anesthesia provider's journey through this whole process, from prep to the OR moments.
The preoperative period is all about meticulous preparation. A thorough history and physical, focusing on cardio but covering everything pulmonary, neuro, renal, hepatic, endocrine, hematologic. Airway assessment is critical.
Any specific things you look for?
Absolutely. Coexisting carotid or peripheral vascular disease. We might need a higher MAP during surgery for brain perfusion. Aortic disease impacts cannulation and monitoring sites.
What about labs?
Comprehensive panel, baseline ABG, electrolytes, kidney function, BUN creatinine, lipids, CBC, coagulation, HbA1c, glucose, maybe biomarkers like troponin or BNP. MRSA swab is common now, guides antibiotic choice.
Medication management must be complex. What stays, what stops?
General rule, continue routine meds morning of surgery with a sip of water. Statins are strongly recommended. Beta blockers definitely continued. It's a quality measure, improves stability, reduces issues. But never start them day of surgery due to hypotension risk.
Anticoagulants.
Feeds careful team discussion. Warfarin stop 5 days prior, aim for INR 1.5, reverse if needed. NOACs are tricky, fewer bleeding issues maybe, but harder to reverse. We rely on specific tests, like anti-sec activity to time surgery.
And preparing for blood loss.
Confirm willingness to accept blood. Ensure type and cross-match is valid, and blood is available, especially crucial for reduced sternotomies or prior radiation cases where risk of injury is higher. Blood needs to be in the room before incision for those cases.
What about the patient's mindset? It must be incredibly stressful.
Hugely important. Acknowledge the anxiety, address concerns about risks, pain, recovery. The pre-op interview by the provider doing the anesthetic builds vital rapport. A mentally prepared patient is calmer, more cooperative. Sedation is individualized, maybe more for healthier patients, minimal for frail ones. Always err on the side of caution, can give more in the OR.
Okay, patient ready. Now the OR setup, a fortress of readiness.
Exactly. Constant team communication surgery, nursing, perfusion, anesthesia is vital for handling emergencies. Closed-loop communication is mandatory for safety.
Monitoring, beyond the basics.
Standard ECG leads to, in V4, V5, with ST analysis for ischemia, core temp, nasopharyngeal or PA cath, peripheral temp, bladder rectal. Arterial line plays pre-induction radial or brachial, site chosen carefully based on surgery plan. Your example, avoid arm if radial artery harvested, use left side if right subclavian used for cannulation. Baseline ABG-KCT from the A line. Central venous access is mandatory right, IJ preferred, ultrasound guided is standard. PA catheter often used, especially with poor function or PHDN, unless recent pacemaker leads. Large bore access for potential massive bleeding. And transoesophageal echo, you can't overstate its value.
Best monitor for ischemia, wall motion.
By far. Plus assessing LVRV function, valves, volume, detecting air, clots, aortic issues, tamponade, guiding cannulas. It's indispensable. Guidelines recommend it for almost all open heart, aortic, and transcatheter procedures. Contraindicated only with esophageal issues.
How is it used? Specific views?
Comprehensive exam has 28 views, targeted maybe 11. We use M mode, 2D, 3D, and Doppler, PWD, CWD, color flow. Remember Bart blew away red toward?
Yeah.
Key views. ME 4-chamber, overall function valves, ME long axis, LVOT, aorta, PG mid-sacs, the donut view best for global wall motion and volume, ME aortic valve, short axis, cusps, PFOs, ME bicaval, guiding lines, PFOs, ASDs with saline contrast. Probe placement is gentle after intubation using standard maneuvers, advance, withdraw, turn, flex, rotate. Other monitors. BIS for anesthetic depth awareness, especially when volatile agents are low on bypass. Cerebral oximetry, NIRS, is crucial for DHCA. Helps assess brain oxygenation, detect cannula issues, potentially extend safe arrest times. A drop below 70% baseline or 50% absolute is concerning.
And anesthetic drugs. Any magic combo?
No single best recipe. Skill in administration is key. Inhalational agents are great cause, some myocardial depression, vasodilation, but offer that crucial pre-post conditioning protection, improving outcomes. Dyslorane N2O have issues, tachycardia, PVR increase, N2O expands, air bubbles, avoid N2O completely. Non-depolarizing muscle relaxant standard, antibiotics per guidelines within 1 hour of incision, 2 hours for Vanco.
The stage is set. Now the intraoperative phase. A delicate dance, critical milestones.
It's intense, fast-paced, high risk. Constant focus needed on the surgery and patient response. Anticipation, prompt intervention, critical communication.
The pre-bypass period has ups and downs in stimulation.
Big swings, high stimulation, intubation, incision, sternal split spread, sympathetic dissection, pericardial opening, aortic cannulation, risk of hypertension, tachycardia, ischemia, managed with the preemptive drugs, increased anesthetic, esmolol, nitroglycerin, low stimulation, waiting pre-incision, conduit harvesting, risk of hypotension, bradycardia, managed with phenylephrine or ephedrine boluses.
What happens right before induction?
Final checks. ID, interview, check for worsening symptoms, listen to heart lungs, confirm blood consent, assess anxiety, set expectations, get large IVs, place invasive lines often after sedation, baseline labs. Central line often waits till after induction.
Induction itself. Stability is key.
Paramount. Plan based on patient factors, procedure, no single best combo. Inhalational agents are good for outcomes. Narcotics may be for severe LV dysfunction. ERAS protocols influence choices now, too.
Incision to bypass, that's a high stimulation zone.
Very. Incisions, sternotomy, sternal spread. Need deep anesthesia, muscle relaxation. This is where recall risk is highest historically. So ensure amnesia. Lungs down during sternotomy.
What about redo sternotomies? Extra precautions.
Huge vigilance. Old grafts or scar tissue might be right under the bone. Review imaging carefully. May expose femoral vessels first for quick bypass access if needed, or even cannulate femorals before sternotomy. Use an oscillating saw slowly. Communication about lung deflation is vital. If there's a major injury, crash on pump, immediate heparin, emergent cannulations, sucker bypass, maintain BP, have blood ready.
After sternotomy,
Conduit harvesting is less stimulating, might lower anesthetic levels. Watch for hypotension arrhythmias from manipulation. Trendelenburg phenylephrine for low BP. Cold breaths for surgical view need apnea alarms on. Sympathetic dissection, pericardial incision are stimulating again. Lifting pericardium can cause bradycardia, hypotension. Treat or ask surgeon to ease tension.
cannulation time, tricky hemodynamics.
Always causes some hypotension dysrhythmias. Crucially, wait at least 3 minutes after heparin. Ensure ACT 480. For aortic cannulation, lower the BP, SBP 9100, MAP 6070 to reduce dissection risk. Deepen anesthesia, raise head, use vasodilators. Confirm cannula placement, check the swing, test transfusion. Then let BP come up, stop vasodilators, level bed. Perfusionist can give volume now.
Okay, what do you do on bypass? What happens?
Perfusionist starts flow. Pulsatile trace disappears. Stop ventilator, maybe low flow O2 or low tidal volume. Keep anesthetic going. Confirm pump vaporizer is on. Stop IV fluids, most meds, except insulin, antifibrinolytics. Pull PA cath back. Insert LV vent if needed.
Then the cross clamp goes on the aorta.
Yes. Perfusionist lowers flow slightly, clamp applied, time noted. Full flow resumes. Then cardioplegia infusion, antegrade first, usually. Watch ECG for rest, widening QRS, then asystole. If not asystolic, need more. Retrograde or osteal infusion also possible. Start active cooling. Run through checklists for safety.
And maintenance on bypass, what are the targets?
Flow rate 50-60 milli-Siemen, CI 2.0, 2.5, MAP 50-60 milli-Hg, maybe 60-70 for older vascular patients. Mixed venous O2 sat 70%. Manage anesthetic depth, treat hypertension, more anesthetic vasodilator or hypotension, phenylephrine pressor. Keep patient fully relaxed, no shivering. Monitor ABGS ACTs every 30 minutes. Correct acid base. Manage fluids, electrolytes, glucose, insulin for hyperglycemia. Watch urine output, 1 LAO-TGHR. Use hemoconcentration, ultrafiltration for blood conservation.
Repair done, heart still stopped. Now the really critical part, coming off bypass, letting the heart fly solo again.
The moment of truth indeed. Preparation is everything for a smooth separation from CPB. There's a rigorous checklist. Air out of the heart. Rewarming complete. Target 36-37 degrees C core temp. Slow rewarming might be better cognitively. Anesthesia relaxation adequate. Stable heart rate rhythm. Pacing ready. Pump flow pressure okay. Metabolic parameters good. ADGs HCT 20-25%. K plus 4 or 5 ionized calcium okay. Monitors working. Lungs re-expanded. Ventilation started. IVs running. Inotropous suppressors ready.
Specific things to watch. Potassium, calcium.
Absolutely. Correct K plus outside 4.0, 5.5 range to prevent arrhythmias. Calcium can boost contractility coagulation, but is controversial. Vasospasm reperfusion risk. Magnesium often given prophylactically. Adequate volume is crucial.
Heart rate and rhythm. Need pacing often?
Optimal is sinus rhythm 70-90 BPM. Temporary pacing wires always play surgery can affect conduction. AV pacing preferred for bradycardia keeps atrial kick but risk of atrial wire tearing. If electrocautery needed post-CPB, switch pacemaker to asynchronous temporarily, then back quickly.
And getting the lungs working again.
Gentle manual reinflation to 30 centimeter H2O. Resume mechanical ventilation. Check for atelectasis, use PEEP recruitment. But don't overinflate in CAD patients risk ITA graft. Resume anesthetic relaxant. Re-zero monitors. Use T and surgeon's eyes to assess function repair adequacy. Start inotrope suppressors if needed. Epi, dopamine, dobutamine for LV, epi, milrinone for RV, or epinephrine for low SVR.
How does the actual separation happen?
Perfusionist slowly clamps the venous line, letting the heart fill. As it ejects, arterial pressure rises, CPV flow decreases. Volume is given via arterial line to optimize preload, then clump arterial line, note time. Immediate post-bypasses, unstable, watch closely. Check for radial versus aortic pressure differences. Reposition PA CAS if needed.
Heart's beating, but not out of the woods. Hemodynamic management sounds like a constant chess game now.
It really is. We often categorize patients to guide management. Group 1. Easy separation, good function, need little support. Group 2. Diastolic failure, stiff LV, volume dependent, may look hypertensive but be hypovolemic. Need careful volume, maybe nitro, high MAP, atrial kick crucial. Watch for LVOT obstruction. Group 3. Systolic failure, weak pump, LV or RV. Need inotropes, epi, dopamine, milrinone, maybe vasodilators, nitroprusside, nicardipine to reduce afterload, IBP for severe cases, RV support if needed. Group 4. Vasoplegia, low BP despite good cardiac output, often resistant to phenylephrine. Respond better to norepinephrine or vasopressin. Vasopressin often preferred less PVR increase. May need non-vasopressor agents too, steroids, methylene blue.
What about bleeding after bypass?
Common, especially after complex long cases. First, check heparin reversal, acetylcholine level. Give more protamine if needed. Corrupt hypothermia, it worsens bleeding. Rule out surgical causes. Remember, transfusions increase risk significantly. Use viscoelastic test, tegrotem, to guide specific product administration. Platelets, FFP, cryo, better than PDPTT. Consider factor concentrates, DDAVP for platelet issues.
Okay, surgery done, bleeding controlled, last steps, getting cannulas out, closing up, heading to ICU.
Right, decannulation. Transfuse remaining pump blood cautiously, watch for overload. Use T to confirm all air is out of the heart, keeping up with the vent. Remove retrograde cannula, LV vent first, then venous cannulas, then aortic root vent. Finally, aortic cannula lower BP, SBP 90, MAP 70 first. Give protamine, test dose or half maybe before aortic decannulation, note time. Check aorta with T for dissection. Give rest of protamine. Surgeon checks for bleeding. Send remaining circuit blood to cell saver.
Closing the chest. Any issues there?
Can decrease preload, increase afterload. Check hemodynamics T before after wires tightened. Release wires if unstable. May need delayed closure, negative pressure dressing, if very unstable or swollen.
Transport to ICU. Risky phase.
Can be. Gather emergency gear. Keep patient sedated. Propofol dexmedetomidine. Remove T-probe, insert OG tube. Thorough handoff to ICU team using a chatless is vital.
Post-op bleeding or tamponade, big worries.
Major complications. Reoperation in 4 to 9%. Indications for going back. 500 milliliter chest tube output in 1 hour, or 200 milliliter sustained. Cardiac tamponade can happen even with tubes and localized compression stops diastolic filling. Suspect if CVPPA pressures rise and equalize, output drops despite support, maybe after chest tubes suddenly stop draining. Classic signs, pulsus paradoxus, Beck's triad, may or may not be present. Immediate drainage, pericardiocentesis, subdoxoid drain, or reorar exploration. Give volume aggressively to optimize preload temporarily. For re-exploration anesthesia, use minimal depressants. Ketamine might be good. Avoid bradycardia. Don't delay surgery for lines. TE guides drainage. Spontaneous breathing until sac opened if possible. Expect hypertension tachycardia after relief.
Wow. Okay, as we understand open heart better, things are getting less invasive, right? Smaller incisions, catheters doing the work.
Exactly. Minimally invasive cardiac surgery, MICS, has come a long way. Doesn't always mean less risk, but survival is generally similar to sternotomy.
Advantages.
Less bleeding transfusion, faster recovery, less infection pain, better cosmetics, but potential for more bleeding sometimes. Femoral access issues, higher conversion rates. Stroke risk with femoral cannulation is debated. Not for everyone contraindicated with diffuse CAD, severe calcification, certain anatomy.
What kinds of approaches?
Partial sternotomy, hemisternotomy, mini thoracotomy between ribs, ports for endoscopic or robotic
procedures.
Mitral valve surgery, often via right mini thoracotomy, great view, less invasive. Robotic mitral repair offers amazing 3D vision, even smaller incisions. Coronary bypass, mid-cab initially, now multi-vessel, via left mini thoracotomy, often off-pump. Total endoscopic KBG TCAB is robotic, multi-vessel, needs specialized skills. Even septal myectomy for HOCM can be done less invasively now.
How do you get on bypass with small incisions cannulation?
Usually femoral artery and vein, percutaneous or cut down, guided by imaging, TE fluoro. Pre-op CT needed to check vessel suitability. Axillary subclavian if femoral's bad. Central aortic last resort. Complications include limb ischemia, emboli, dissection, coronary sinus cannulation or retrograde plegia done via IJ vein, guided carefully. An alternative to an external cross clamp is the endoaortic balloon, EAO, inflated inside the aorta, can deliver cardioplegia too.
Anesthesia for MICS. Different challenges.
Specific positioning, often one lung ventilation needed. Expert T is vital. More heart manipulation means trickier hemodynamics. Need external defibrillator pads. Air removal can be harder. Focus on fast-track recovery, less narcotics, multimodal pain relief, prompt reversal.
And if even MICS is too risky, transcatheter option.
That's the next frontier, transcatheter interventions. Huge for high prohibitive risk patients. Decisions made by the multidisciplinary heart team.
TAVR is the big one. Transcatheter aortic valve replacement.
Yes. Usually retrograde via femoral artery. Alternatives if femoral's bad. Transapical, transaxillary, subclavian, transcarotid, transaortic, transcaval. Class 1 for high prohibitive risk. Class Thea, intermediate. SAVR, still standard for low intermediate risk for now. Uses balloon expandable, BE, you don't see Edward Sapien, or self-expanding ST Medtronic core valve.
How do they deploy it? Need to stop the heart briefly?
For balloon dilation and BE valve deployment, yes. Use rapid ventricular pacing, 200 BPM, via temporary wire or the valve guide wire to drop cardiac output momentarily for stable placement. Treat instability with pressors. SE valves often don't need pacing and are repositionable.
Complications.
AV block needing pacemaker, more with SE core valve. Paravalvular leak around the valve. Stroke, hence cerebral protection devices, CPDs are used. Vascular access issues, rare. Aortic rupture, coronary obstruction, valve migration.
What about the mitral valve? Transcatheter options there.
For mitral regurgitation, yes. MitraClip is the main one. FDA approved for high-risk degenerative mitral, based on surgical Alfieri stitch clips leaflets together to create double orifice. Class I recommendation for high-risk symptomatic severe Mr. Needs T and fluoro guidance, usually under general anesthesia.
Cerebral protection devices helping with stroke risk.
Yes, CVA rates aren't negligible, around 9% TVR, 4% MitraClip. Devices like Sentinel filter the major arteries supplying the brain during the procedure. Quick to place, reduce embolic events.
Anesthesia for these transcatheter cases. Hybrid auras, GITA versus MAT.
Often in hybrid auras or EP labs, most need GITA because T guidance is essential. But for transfemoral TVR, MAC, monitored anesthesia care, is increasingly used, maybe with TTE or ICE instead of T. Great for frail patients, avoid intubation, maintain spontaneous breathing, needs skill-balanced sedation, airway hemodynamics with midazolam, fentanyl, dexmedetomidine, allows neurochecks, may shorten LOS.
Truly amazing advancements. Finally, for the most severe end-stage heart failure, what are the ultimate options? Mechanical support and transplant.
That's right. Mechanical circulatory assist devices, MCADs, provide critical support. Demand is rising. Devices are smaller, better, last longer.
VADs, ventricular assist devices, used as a bridge.
Bridge to survival, recovery, decision transplant, or increasingly, as destination therapy, DT, the final treatment. One-year outcomes for long-term VADs now rival transplant. Over 70% are DT now.
What about short-term support?
IABP, intra-aortic balloon pump, still used, sometimes counterpulsation improves coronary flow, reduces afterload. ECMO, especially VA ECMO, provides full heart-lung support for cardiogenic shock, failure to wean, etc. Cannulation central or peripheral. Circuit involves pump, oxygenator, heat exchanger. Can increase LV afterload, cause LV distension. ECMO lung needs careful management. Short-term VADs like Impella, microaxial pump unloading LV or RV, tandem heart, percutaneous LA femoral bypass, and Centrimag, external centrifugal pump for LVR VBV support, adaptable for ECMO, offer powerful temporary support.
And the long-term durable VADs.
For NOAHE Class 3, despite max medical therapy, InterMAX's scale guides timing. 3 main continuous flow LVADs. HeartMate 2, axial flow, older. Heartware HVAD, centrifugal. HeartMate 3, centrifugal, magnetically levitated artificial pulse. Centrifugal, HVAD, HM3 have much better outcomes, less thrombosis, stroke, reoperation. HM3 showing excellent results. For biventricular failure, the Syncardia Total Artificial Heart, TAHET, is an option as bridge to transplant.
Anesthesia for VAD implant. T is key again.
Absolutely essential. Pre-CPBTD checks for issues needing correction. AI, TR, PFO, thrombus. Guides placement. Monitors RV-LV function throughout. Post-CBB assess function, D-air device. RV dysfunction is common, 30%. Post-LVAD treat with inotropes, pulmonary vasodilators, inhaled epoprostenol, I know. May need RVAD VAD. LVDs are very preload afterload, sensitive, manage volume meticulously, treat bleeding fast, prevent suck down, especially axial flow with volume, ensure good cannula position, TE. Vasoplegia, common use vasopressin, treat hypertension to avoid LVAD stress, rehospitalization, common infection, bleeding, RHF, thrombosis, stroke.
And the ultimate option, cardiac transplantation.
The gold standard for end-stage failure. Huge progress since Barnard in '67, especially with immunosuppression like cyclosporine. Survival now, 90% at 1 year, 80% at 5 years. Early issues. Rejection, infection, graft dysfunction, AKI. Big challenges, donor shortage.
How are hearts allocated?
System. 6 tiers based on urgency. Status 1 highest. Matching by blood type, size, distance. Ischemic time, critical ideally 4 hours, max 5 hours. Anesthetic timing coordinated carefully.
Surgical technique.
Mostly by Caval now, 5 connections.
Yeah.
Rather than older by atro.
Anesthetic considerations for transplant.
T essential. Prevent PVR increase pre-CPB. Full heparin. Temporary pacing wires placed post-CPB conduction recovery takes time. Critically, the donor heart is denervated, won't respond to indirect drugs like atropine. Intrinsic rate 90-110 BPM. Use direct-acting inotropes. Titrate with T. Frank Starling mechanism works very preload dependent. Manage PHTN with inhaled vasodilators. Slow protamine infusion, blood conservation vital. Minimize alloimmunization.
One less specific, high-stakes area. Surgery on the aorta itself. Aneurysms, dissections.
Yes, surgery on the ascending aorta and aortic arch. Aneurysm, 50% dilation, versus dissection, intimal tear. Often genetic causes in younger patients, Marfan, etc., acquired HTN atherosclerosis in older,
Aneurysms often silent.
until large enough to cause mass effect symptoms. Need surveillance for high-risk patients, bicuspid valve, genetic. Surgery if symptomatic, or 4.5 centimeters congenital, 5.5 centimeters acquired, or growing 0.5 centimeter year. TE vital for assessment.
Dissection is an emergency.
Acute type A ascending arch dissection is highly lethal, needs urgent surgery. Type B, descending, often managed medically unless complications. Presentation, sudden severe pain, can mimic stroke MI. Syncope, bad sign. Priority, access, BP control.
How do you manage BP in dissection?
Control shear stress. Beta blocker first, HR60. Then vasodilator, nicardipine, NTG, nitroprusside, to MA6070. Vasodilator before rate control is dangerous, increases shear stress. Tricky if heart function already poor. May prep drape before induction due to rupture risk.
Repair technique.
Ascending aorta, simple tube graft, supracoronary graft, spare sinuses, replace valve aorta. Or root replacement if annulescence is involved, either valve sparing, David procedure, or composite valve graft, Bento procedure, reimplanting coronaries. Arch repair is most complex due to brain vessels. Needs deep hypothermic circulatory arrest, DHCA. Hemiarch or total arch replacement, maybe debranching. Often staged with elephant trunk technique for extensive disease.
Anesthesia for aortic surgery. Specifics.
Airway can be tough. Compression. Strategic A-line placement. Consider cannulation clamp sites. Cerebral perfusion brachial, often good for arch DHCA. PA cath usually needed. Massive access for volume blood. Expect significant blood loss coagulopathy. Graft material effect. Meticulous temperature management post-DHCA. Rapid infuser. Antifibrinolytics. Hold during DHCA. For AI, with dissection, control shear stress first. Rate control, then vasodilation. Overriding typical AI goals.
Tell us more about DHCA, deep hypothermic circulatory arrest.
Used for arch repair when you can't clamp normally. Interrupts brain perfusion. Hypothermia drastically reduces brain oxygen demand, CMR2. Cool patient via CPB. Head cooling. Target temp 14-20 degrees C. Depends on cerebral perfusion plan. Aim for flat EGBIS 0. Safe arrest time 20-30 mins alone, up to 80 mins with cold antegrade cerebral perfusion, ACP. NRS monitoring critical. Hemodilution helps cooling. Propofol helps reduce CMR2, but hypothermia is the key neuroprotective.
What is antegrade cerebral perfusion, ACP?
Perfusing cold blood, 6-12 degrees C, directly into brain arteries, axillary, innominate, etc., during DHCA if 30 mins needed. Extend safe time. Monitor pressure via right radial A-line NRS for bilateral flow.
And retrograde, RCP.
Less common now. Infusing cold oxygenated blood backward via SVC. Simpler maybe, but ACP, generally better outcomes.
Rewarming after DHCA.
Gradual. Max 10 degrees C gradient. Pump arterial versus patient venous. Keep arterial temp 37 degrees C to avoid cerebral hyperthermia. Separation temp debated. 36.5 degrees C for less bleeding versus 35 degrees C for brain. Coagulopathy is significant post-DHCA. Need platelets, FFP, cryo, guided by viscoelastic tests. Hemodynamics challenging, transport intubated sedated.
So what does this all mean for you? We started with that simple phrase, take care of the pump, pipes, and volume. But wow, the layers underneath, the physiology, the technology, the skill, It's profound.
It really is. That phrase captures the essence, but the execution requires incredible depth of knowledge.
We've journeyed from myocardial oxygen balance, stunning, preconditioning, hibernation, through heart failure types,
Yeah.
DABG, OPP,
The valves AS, HCM, AI, MS, MR, each needing a unique approach.
into the heart-lung machine, CPB, its components, anticoagulation, cardioplegia, the body's inflammatory response.
Follow the whole perioperative path. Prep, monitoring like TE, induction, critical phases like cannulation and separation, managing hemodynamics and bleeding.
And finally explored the frontiers. MICS, TAVR, MitraClip, VADs, transplant, and complex aortic surgery with DHCA. It's an incredible orchestration.
It truly is. A seamless collaboration between anesthesia, surgery, perfusion, nursing, all focused on every single variable.
Hopefully this deep dive has helped you move beyond just knowing about it towards really mastering the information, understanding the why behind these critical decisions, just like the top professionals in this field.
Absolutely. Mastering this is about seeing the connections, understanding how every system interacts, how every decision impacts the whole. It's meticulous support of life itself using amazing ingenuity.
A final thought for our listeners.
Well, consider this. As technology keeps rocketing forward, less invasive procedures, more sophisticated support devices, what new ethical and practical challenges emerge? How do we balance the costs, the access, the equity of distributing these incredible life-saving interventions to a growing global population facing more heart disease? Something to ponder.
A profound question indeed. Thank you for joining us on this incredibly detailed deep dive. Until next time, keep learning, keep exploring, and stay curious.